This is the Northern Ireland Assembly Senate Chamber programme time.
Recording apologies. I have none received. Are any apologies? No. Okay, members, just under chairperson's business, I want to raise the issue about the MRI scanner that has been in the media in the last number of days. I'm seeking committee's approval to write to the Minister to clarify the situation around the delay, as to, particularly on the back of the press release that was fairly well covered in the local press today, that there had been a date of 2013-14 to actually have the scanner operational. So I think it would be useful if the committee sought the clarification on the rationale or reasons why there has been a delay in the installation of the scanner, and also how much private sector investment has went into the delivery of the scanner in the interim. So if members are in agreement.
I think to be fair, I think it's good we could ask for a programme when the work is going to be carried out, when the installation will be complete. I think the Minister did make a number of points in relation to that, and that there were site works to be carried out, there was to be asbestos removed from the building. It was a complex bit of equipment that needed commissioning, so there is quite a lead-in time. In reality, it will take some time before the installation is up and running. So those are all factors. Those considered, I think it would be important that we get a timetable of when the work is likely to be scheduled and the equipment commissioned.
And an explanation why the timetable wasn't followed, the previous timetable wasn't followed.
Yeah, I think what we're saying, yes, and I take that point, but we want to get the rationale as to why the delay, why the timeline wasn't met. And yes, you're right, Gordon, I have no difficulty. We should seek a timeline on when this will be fully operational, as well as I said, the cost to date. So if members are in agreement, we can seek that from the Minister. Secondly, just under chairperson's business, coming from the Minister's statement this week on transforming your care, I think first and foremost we should seek clarification from the Minister. The statement had indicated that there's 42 million of a shortfall in relation to the transitional funding that had been estimated to actually implement transforming your care. The figure of 70 million had been estimated. The statement a number of days ago had highlighted there's actually 42 million shortfall. So again, I would seek members' approval that we would seek clarification as to, does that shortfall A mean that transforming your care transition is at risk, and B, where will that 42 million be sought from, and is there any indication of timelines as to when that actual funding could be in place? So again, I'm seeking members' endorsement to do that. Members' agreement. Thank you for your agreement. Also, I want to advise members that next Wednesday the committee had scheduled the meeting to the emergency department at the Royal. Just reminding members that the consideration stage of the local government bill has now been scheduled to take place next Tuesday and Wednesday. It's not possible, members, to predict at this stage what time the plenary will finish on Wednesday, and I know that members would wish to be in the chamber at that stage. Therefore, I'm proposing that the committee postpones a visit to the Royal and does not schedule a meeting for next week. Are members in agreement with that?
Great.
Okay. The committee are also sponsoring an event in the Long Gallery on Wednesday for Leukemia and Lymphoma NI. I will be doing the opening remarks as chair, and hopefully some of the committee will be able to attend.
What time is that?
It is
Chair, it starts at approximately 11 o'clock.
11 o'clock. Thank you. Okay, members, moving on to item 3, which is the draft minutes of the meeting on Wednesday, the 26th of February. Can I refer members to the draft minutes? Are members content? Thank you. Item 4 is the review of waiting times and evidence session with Mike Lyon. I want to refer members to the response from the Minister regarding the Department's approach to waiting times, which is at page 13. The committee will want to come back to this information when it holds the evidence session with the Department on waiting times towards the latter part of our review. So I want to welcome Mr Mike Lyon. You're very welcome to the committee. Senior Advisor on waiting times for the Scottish Government. Certainly appreciate you taking the time. This is obviously something that has not only the committee but I think the wider society quite perplexed as to get the solution. So the normal procedure here is I want to refer members first of all to the presentation that has been circulated at page 2 of your tabled papers here today. I'm going to ask Mr Lyon to make a 10-minute presentation and then we'll invite questions from members.
Okay, thank you very much indeed for inviting me here to give evidence of Scotland's challenges and successes in reducing waiting times. It's always a pleasure to be in Northern Ireland. Much of what I say will be familiar to members around this table and the NHS in Northern Ireland, for example, through your quality strategy. I'd like to focus on 3 themes: underpinning principles, service improvement and performance management, information systems, definitions and measurement. In addition, I'll highlight 10 key aspects of Scotland's approach to improving waiting times that I think may be relevant to Northern Ireland. I've provided those in the handout. Underpinning principles. The 2003, that's pretty much when we started this in earnest, Good Practice Guide on Managing Waiting Time states that the patient's rights are paramount and patients are to be offered care according to clinical priority and within agreed waiting times. Clinical priority is not to be compromised under any circumstances. The Patients' Rights Act legislates that it is the right of every patient to receive care that is patient-focused, takes account of the patient's needs, provides optimum benefit, keeps the patient informed, encourages the patients to participate as fully as possible, treats the patient with dignity and respect, privacy and confidentiality, is caring and compassionate, is based on recognised clinical guidance and causes no avoidable harm or injury. Now, that's a long list of aspirations which I think everybody will agree to, and it is in your quality strategy. The point is, it is in pursuance of those rights that all reasonably and practical steps must be taken to ensure clients with a legal treatment time guarantee. We have a legal guarantee, but the same principles account to all our guarantees. Waiting times are in pursuance of patients' overall rights. Taking account of the patient's clinical needs and the clinical needs of other patients, including the patients who are undergoing unscheduled care. Waiting time standards are part of an overarching Scottish NHS strategy for quality. Waiting times are managed as one of the 6 dimensions of quality: effective, efficient, safe, patient-centred, equitable and timely. We have a 2020 vision that sets out a strategic vision for achieving sustainable quality in the delivery of care and is supported by a quality strategy. This quality strategy builds on significant achievements to date, such as improving waiting times. So it's all meant to tie together. Scotland's quality ambitions are further supported by the Scottish Patient Safety Programme, the Quality Improvement Hub, HEAT targets covering health improvement, efficiency, waiting times and appropriate treatment, the 2020 Workforce Vision, Healthcare Improvement Scotland, which, among other responsibilities, develops evidence-based advice and guidance, and public annual reviews of each NHS board. In summary, it is Scotland's policy that waiting times are part of an overall quality strategy applying to all areas that places the patient at the centre. Waiting times should be an outcome of high-quality, efficient services. Service improvement and performance management. Service improvement and transformation of services have been central to Scotland's drive to improve waiting times. Improvement programmes have utilised change and improvement methodologies, for example, the improvement model, statistical process control, queuing theory, lean, demand, capacity, activity, queue, flow analysis. I will say something more on the 3 central concepts of queue, pathway, flow in my summary. Performance management. Improvement of Scottish waiting times has been supported by very strong central performance management. I led it for 5 years, and it was very strong, through collaboration with NHS boards. For example, monthly improvement trajectories towards targets are agreed with each board chief executive individually. Regular review meetings are held. Where progress is not satisfactory, binding recovery plans are agreed. Weekly performance management is introduced where required. Board capacity plans can be assessed and amendments recommended or mandated. Tailored support and peer monitoring can be initiated. Additional funding is related to performance and to achieve best value. Clinical engagement. Effective clinical engagement is fundamental to delivering Scottish waiting time standards. For example, the delivery of the referral to treatment target for cardiac services was led by a clinical group. Delivery of the 18 weeks referral to treatment standard has been supported by a number of clinically led task of finish groups. There have been clinical champions for service improvement in each NHS board. A musculoskeletal and orthopaedic quality drive is in place, which extended out of our waiting time improvements. Fundamentally, the Scottish drive to improve waiting times has been based on a collaborative approach to both service improvement and rigorous performance management. Information systems, definitions and measurement. The improvement of waiting times in Scotland has been supported by the implementation of a wide-ranging e-health strategy, covering, among other programmes, a unique patient identifier, the e-referral programme, digital imaging and extensive upgrades of IT systems. Historically, information systems, as I'm sure you will know in the NHS, have managed discrete episodes of patient care, and a great deal of NHS activity has not been recorded electronically. A suite of products known as a patient management system have been nationally procured, and boards are implementing IT systems that can support the management of patients across entire pathways of care. A suite of definitions is available to support consistent measurement and management and reporting of waiting times. The 18 weeks referral to treatment standard was supported by an information strategy and delivery team. After more than 5 years, that information team is still very busy. Specific enhancements to the available information set were put in place, including a unique pathway number for each individual 18-week pathway, clinic outcome codes to identify when an 18-week pathway continues or when it has stopped, an onward referral data set to transfer pathway information between NHS organisations. Upgrading IT systems and establishing effective definitions and measurement have been central to delivering a referral to treatment standard. We couldn't have done it without that. In summary, Scotland moved from a simple 18-month maximum waiting time for inpatient stay cases in 1991 to a portfolio of waiting time standards in 2014, covering GP access, accident and emergency, stage of treatment, referral to treatment, diagnostic tests, cancer, child and adolescent mental health, psychological therapies, drug and alcohol treatment, audiology and hip fracture. The majority of the improvement was achieved over a period of 10 years. The delivery of an 18-week referral to treatment standards was preceded by successfully delivering successively shorter targets for outpatients and inpatients, introducing targets for 8 key diagnostic tests, which covered about 80% of all diagnostic tests, and initial referral to treatment standards for cancer, coronary heart disease and cataract surgery. Initial referral to treatment standards were managed by using patient trackers who manage the progress of the patient through a pathway in cancer, or by dividing the pathway into times for assessment, testing and treatment that added up to the whole journey and actively driving out administrative delays. These initial methods were replaced by actual referral to treatment measurement as information systems were upgraded. So we achieved a referral treatment standard incrementally over time. A few words on the concepts of queue, pathway and flow, which are central to our improvement agenda in Scotland. Queues. Stage of treatment targets are essentially queue targets, and to manage queues, it is necessary to have queue information identifying the number of queues, the size of queues, scheduling of the queues and variation, additions and removals of the queues. I think a previous person giving evidence, Rob Finlay, identified the same issues with regards to queues. Pathways. Queues are generally contained within pathways, and referral to treatment targets measure the time between the start and finish of a pathway. To manage referral to treatment targets, it is necessary to design and manage pathways effectively. Flows. Elective or scheduled care targets are part of overall hospital and healthcare provisions that include unscheduled, for example, accidents and emergency, as well as scheduled care, and is influenced by care outside the hospital. To manage scheduled care targets, it is necessary to take account of flows of both scheduled and unscheduled patients through a hospital. And just a brief point, it's our view there should be a focus on the wider spectrum of healthcare. Demand in hospital care and challenges to elective care targets are influenced by the quality and extent of care outside the hospital and by the health status and behaviours of the population. The extent and quality of primary care and the support for social care, for example, support to carers, will have a direct impact on the resource requirements to deliver elective waiting time standards. Successful health improvement actions will ultimately impact positively on elective waiting times. The more effective the relationship between health and social care, the more effective healthcare will be overall. And we are moving towards integration of health and social care, which I believe you have achieved. So, in summary, the 10 key aspects of our approach to waiting times in Scotland, it may be of some interest to yourself here, are 1. A forceful central performance management team working in partnership with NHS boards. Skilled central support for service improvement integrated with NHS boards, your local organisations. A strong emphasis on the determinants of waiting times, primary, secondary and social care, demand capacity management, queue pathway flow, the relationship between scheduled and unscheduled care, workforce and, yes, financial resource. 4. The planning of waiting time standards within a broader strategic and quality improvement approach. 5. Effective clinical engagement. 6. The development of waiting time standards over time, building on success step by step from stage of treatment to referral to treatment. 7. The development of information systems, measurement and definitions. 8. The use of the independent sector at the margins and for a limited duration to manage unexpected demand and unforeseen events. 9. The allocation of funding in the short term to address need, but the balancing out of recurrent funding in line with the national funding formula. The allocation of funding to support service improvement as well as to increase capacity. And finally, 10. Targets should be fit for purpose, will provide real benefit to patients, can be measured and reported, can be delivered, are affordable, promote effective care and resource efficiency. Thank you for listening to this brief summary.
Thank you. It's very useful. I noted that you said about the wider emphasis required on the wider spectrum of healthcare. Could you maybe expand on that a bit? Obviously, you're indicating that requirement or that emphasis would have an impact then on waiting times?
The emphasis on, for instance, health in early years will impact on individuals' health in later years and the requirement for care of the elderly. Of course, that takes time to work through. Support for carers in the short term can have an impact on patients admitted to hospital. Providing good care or assessment for patients before arrival at A&E will reduce your demand into A&E and your pressure in beds and can aid both emergency and elective care.
So it's effectively early intervention prevention model that you're looking at?
Early intervention prevention, care in the appropriate setting. For example, we've reduced referrals in a number of areas to orthopaedic surgery significantly by having appropriate allied health professional and physio care in the community. These people never needed to come into hospital.
Okay. And specifically in relation to the referral to treatment issue, what were the drivers in terms of making sure that was used or utilised as a particular approach?
Well, it was clinically popular. Clinicians recognised the idea of a pathway, referral to treatment. I think it was instinctively felt right in the sense of that's what the patient experienced. The experience from hospital, they're medically fit and are not remaining in beds where there's no benefit to them. If we have anticipatory care where a person's chronic obstructive pulmonary disease or diabetes is managed before they hit hospital, that's all going to take pressure off hospitals, and particularly the pressures we get when you're facing A&E pressures. That's often about, which I tried to pull out there, the flows of patients coming through A&E and the flows of patients for acute care. You may find that orthopaedics admits all their patients on the day that you have your biggest emergency flow in, or the doctors only do the ward rounds every second day, so your patients sitting in beds unnecessarily. So it's getting all of these different aspects flowing together.
Okay, that's one. Thank you.
Thank you. Roy?
Again, thanks for your presentation. It's always interesting to learn from someone else's similar problems and address it perhaps slightly differently. On the back of one of your papers, you've indicated that in terms of managing new attendance at emergency departments, you have a target of reducing the number of attendants by about 2%.
Yes.
Can you explain, well, are you on target and how have you achieved that?
Not to make excuses, it's not my area, so I don't actually know if we're in target or not. But we have a programme of shifting the balance of care, which is to provide care for patients outside hospital. We have NHS 24, which is an advice and helpline. You would go through that before you call an ambulance. We have pharmacists are providing more advice to patients. There's a programme around that. We'll be aiming to have GP surgeries open longer hours. We have a 48-hour standard for access to GP, to the appropriate person within the practice, not necessarily to the GP themselves. So they are all ambitions to actually shift the balance of care away from the hospital.
And how long have you had these new policies in? I'm not sure what standards there are in Northern Ireland, so just how long have you had these in?
The GP standard's been in for, I think, at least 5 years. Shifting balance of care programme, we've been running for that period of time. The reduction in attendance at A&E, I can't recollect off the top of my head, but certainly several years. Okay,
great. Another area then, if I may, just quickly, in terms of the measuring the time on a waiting length, the RTT, referral time to treatment, how long did it take for you to switch over from the old way of recording to the new system, and what level of investment has been required?
Right. It probably took about 3 or 4 years. I mean, from the official launch of the launch document to actually our first going live, I think was 4 years, if I recollect correctly. And there was marked investment behind this. We had an investment anyway in our e-health programme. Our patient administration systems were falling over, so we invested in patient management systems that can actually track patients from end to end. We invested in diagnostic information systems. A small area like audiology had patient-based, paper-based systems, so all that was put in place electronically. We put in a unique care pathway number because a patient could be in several pathways: diabetes, respiratory, their knee replacement at the same time. So that was a significant information investment.
And when you went to this new system, were there inefficiencies with the old system shook out? You know, lots of different queues, admin, and how did the patient's experience change?
Our patient satisfaction surveys give about 80–88% satisfaction with their waiting times. And again, amount of this is in patient satisfaction, but which indicates there is an improvement in satisfaction in their overall waiting time. Administratively, I would argue that it has made life easier and saved money. Again, we'd have to gather full evidence on that. But managing a lot of queues and long queues is costly administratively.
Just a final point, if the private sector is used, does the patient remain on your queue, or do they disappear?
No, they remain in the queue until they're treated.
Just on that issue, I'm uncertain what happens here. I came across a patient who's just hit 6 months and they've been transferred to the private sector, and still to get a date, they're just sitting on another queue.
Okay, Gordon.
Thanks, Chair. Thanks very much, Mike, for coming over and talking to us.
Pleasure.
It's been very informative. Just on handling of data, I suppose, getting down more to specifics, was there a major issue there in relation to waiting lists? Perhaps a lot of the data was out of date, not handled properly, needed cleansed. Is that an issue?
Over the 10–12-year period, there's been a constant work programme on getting the data right and fit for purpose. We started off with waiting lists, and then they had to be made more accurate. We needed electronic recording of data. We had something called a New Ways project and a Refresh project, which is all designed at making our data more fit for purpose. We spent a lot of time in agreeing definitions and guidance for managing waiting time, so as far as possible, hospitals are managing patients the same manner. A degree of local flexibility, but it should be the same wherever you are.
Have the same system in place across all the various trusts?
Over half of Scotland are covered by a system called TRAC, which is a patient management system, and the other management systems have similar functionality.
Right, and has that gone some way to trying to make the list more efficient and effective?
Yes, it has, and we also have an e-referral system with something called Sky Gateway, where GPs can make electronic referrals, and that's increasing as well. We're using electronic systems in around AHPs, and I think we're upgrading the GP system as well.
What sort of funding is required for installation of such systems?
I don't have that to hand. I could provide it, but it's millions of pounds.
The other issue we keep talking about is the risk of a conflict of interest between consultants doing private work and working in a trust or working for health boards. Have you any evidence of that can be a risk?
No, I don't.
What's your opinion on it?
Well, I think the neater the separation between private and NHS work, the better. In fact, if we commission a private organisation to do work for NHS patients, they're commissioned as a private organisation and the patients stay on the waiting list. One NHS board will not use consultants from the local area. Other areas, that's very, very marginal. Except for the possibility of cardiac surgery, we don't treat private patients in NHS hospitals. So there's a strong separation between the private work and the NHS work.
You don't treat private patients in NHS hospitals?
As far as I'm aware, apart from possibly cardiac surgery, because there's no private hospital that can set up a cardiac unit. It's too specialised. There's a private hospital, several in Edinburgh, several in Glasgow, one in Dundee, one in Aberdeen, Ayr. So they're private facilities without needing to use hospital facilities.
So they're working independently of each other?
They're working independent of the NHS. The doctor will have a contract that will allow a certain amount of work in the independent sector, which the doctor should not exceed.
Okay, thanks very much. Thanks, Chair.
Okay, thank you for that. Gordon, and thank you. It's been very informative. I suppose where we take this to, we'll be certainly reflecting on the information you give us today. It might be useful as well if you were willing that we could share our findings with you in terms of any recommendations that we would come up with. Probably the important message coming from your presentation and evidence today is the central performance management system, and in your words, actually a forceful central performance management team. And I think that brings up its own issues around governance and accountability that we have to look at, I think, in our own situation here. So I want to thank you for taking the time. It's been very informative. If you are willing, we would share our recommendations with you, and feel free to feed back into our views.
We're very happy for you to share the recommendations. I know on behalf of the Scottish Government, we're very happy to provide any support and advice that you may find useful.
Okay. Appreciate that. Thank you very much for your time.
Thank you for having me here. Thank you. Bye.
Okay, members, moving on to item 5 is the review of transforming your care and older people supported living. It's the evidence session with the Health and Social Care Trusts. There's an assembly research paper at page 18 and briefing papers from the Southern and Northern Trusts at page 41 and 50. I also want to refer members to the briefing papers from the Belfast, South Eastern and Western Trusts, which are at page 16 of the table papers today. Also, the Department's briefing paper from last week, for reference, is at page 40 of the table papers. And we're just waiting on our guests. Okay, folks, you're very welcome. Hopefully I will get all your names and titles correct. First of all, we have Melanie McClements, who is the Assistant Director of Older People at the Southern Health and Social Care Trust. Marie Heaney, who is the Co-Director of Older People Services at Belfast Health and Social Care Trust. Mrs Una Canning, who is Director of Primary and Community Services for Older People at the Northern Health and Social Care Trust. And we have Mr Alan Corey-Finn, Director of Primary Care and Older People Services, Executive Director of Nursing at the Western Health and Social Care Trust, and Ms Nikki Patterson, Director of Primary Care, Older People and Executive Director of Nursing at the South Eastern Health and Social Care Trust. So you're all very welcome. Just to inform yourselves that the committee has obviously read the briefing papers and would have a number of issues that we would want to explore further. So we're just going to move directly to questions. I want to also just advise the Trust representatives that the committee's purpose today is to gather the facts and figures around the Trust's approach to supported living. So I would therefore ask for your indulgence and that you keep your answers to that topic of supported living. Some of you have provided information in your briefing papers about other issues, and that's useful information. But it is about reablement and domiciliary care, and we're not here today. I just want to make that point to engage in that general discussion. I want to keep us very focused. We want to stick to the topic of supported living. So, given also that there will be many questions, I would suggest to each of the trusts, again, I'm asking you just maybe to keep the answers short and to the point. So, I'm just going to move directly into questions from members and asking people to work as best we can to have the proper outcome that we require in terms of facts and figures. So specifically, if I could maybe start, just having worked through this particular issue in terms of evidence in the last number of weeks, and we obviously had the department with us very recently in relation to supported living. I'm specifically interested in what the Trust's views would be or understanding of the department's policy in relation to supported living accommodation for older people. I'm not sure which one of these wants to lead on that, or.
Well, I think our interpretation of the department's view on supported housing is that it's part of TYC and it's an option that should be developed within trusts for a very small part of the older population who would like to opt for this choice. So,
can I just ask? Sorry, and I don't want to be interrupting you, but is it not supported living, which is very different from supported housing? Is that not accurate?
No. I think there is issues with the definitions.
Okay.
The trusts. I mean, obviously, the term assisted living, I think, originated in America. And locally, it became known as housing with care, and then it morphed into supported housing. So the trusts are here today speaking specifically about supported housing, which is a partnership model between health and care trusts, particularly the social care dimensions to trusts, and housing associations to share or pool their expertise in housing and care to provide a model of support which allows people to have their individual homes, their front door, while receiving 24-hour support as an option. Instead of, for example, domiciliary care or residential or nursing care even. So we interpret it as an option we like to provide for people who like that, who would benefit from that model of care. But it is small.
Okay, and just by way of leading on from that, in Transforming Your Care, there was a specific reference to supported living. So in your view, does the department then have, from the Trust's perspective, have a clear policy which is articulated to the trusts?
Well, my understanding is that supported living is broader than just the accommodation-based issue. I mean, for example, we do have things like floating support. We have peripatetic services that's provided to people either in their own homes or people who are within, say, sheltered housing. To allow them to still keep within the tenancy and to do that. So supported living is the broader option, but our understanding of today is the discussion around the accommodation or the housing part of that.
Okay, okay, and I'll maybe come back to that because there's a number of members who have indicated. Firstly, I have Sam.
Okay. The Southern Trust. What is your understanding of your Trust's role in the future provision for supporting living accommodation for, it says older people here, but I say senior citizens?
Okay. At the minute, we have quite limited provision within Southern area. We have got 3 current schemes, one of which was developed in partnership with the Trust, and 2 which are run independently by Abbeyfield UK. The capacity across those 3 supported housing schemes is only for 41 older people, and is fairly limited. It is a fairly low turnover within that, and normally we have waiting lists. At the minute, we are in a lucky position just by default that there are currently 4 spaces within the 41 units in Southern area. But it is our intent to increase the capacity by over 100%, and we have applications currently at different stages of planning for 48 new tenancies across 3 new builds, one of which is hopefully going for planning appeal on the 19th of March, and the other 2 which are past the outline business case approved and in the capital year for 14-15.
Sorry, could I just say I need to declare an interest here. I'm actually representing residents opposed to that application, so just I didn't realise you could have specifically mentioned it, so I'll stay clear of any comment on it.
I thought you were one of the residents.
No, I'm not that age yet.
What areas are you allocating?
The one that Jim's referring to is in Kilkeel, and it's for
him.
It's a 12-unit frail elderly new build on the Old Mourne Hospital site. The other 2, there isn't a definite site identified, but the areas have been identified as somewhere across Craigavon and Banbridge council areas and somewhere across Armagh and Dungannon council areas, informed by the needs assessment and the demography and the rurality issues and a range of, obviously, planning assumptions that we've used to come up with those 2 areas. They're both for 18-bedded accommodation bills with frail, elderly and low to medium level dementia.
When you talk about 18 bills and things like that, is this where they will spend the twilight years of their life?
Some may well do, and some may well need a further transition into either residential or nursing care, but some may well spend their late years in supported living and end their days there, but some may have further needs and need ongoing 24/7 options within residential or nursing facilities.
Thank you. Wish you well.
Thank you.
Maybe just from the other Trust's perspective on that question of your role in the future provision of supported housing, maybe if we could ask briefly the other Trust to.
Well, I suppose from the Western Trust point of view, I mean, we work in conjunction with the housing executive doing the main assessment of need for the area, but we would be obviously highlighting specific areas of need and also encouraging the independent sector to develop facilities. We're pretty well provided for across the Trust locality, with the exception of the Strabane area, which we're in the middle of an assessment of need at the moment.
Okay.
And I'll maybe say for the Northern Trust, we have 2 supported living schemes. We have the Brook and Coleraine that has 55, there's capacity there for 55 tenancies for people mainly with dementia, but some older people there as well. We have another then facility in Barnholt in Carrickfergus, and we have 26 tenancies in there. In terms of our planned supported living schemes, there's one for Newton Abbey for 24 places for people with dementia. Again, Green Island, there's plans in place for 36 places for frail elderly. And Ballycastle, there's planned in place for 28 places for frail elderly as well. In terms of then the broader aspect of supported living, we would also have some peripatetic floating schemes within Newton Abbey, Coleraine, Macrofelton, Cookstown, and we have plans this incoming year for Antrim, Ballymena and Moyne.
Okay.
And then from a South Eastern Trust perspective, our intention is to have an accommodation-based scheme in each of our 4 localities. We currently have an accommodation-based scheme within the Lisburn locality with 23 places in St Paul's Court in Lisburn. and an accommodation-based scheme in Cedar Court and Downpatrick, which opened in August of 2012, and that's 24 places. And then we have Kew Court in Newtonards, which is due to open again with 24 places at the end of this coming month, the beginning of April. And a further scheme then planned for the Bangor area, and again that will be 24 places.
Okay, thank you for that.
And for Belfast, Belfast has 4 supported housing schemes, providing 130 tenancies, with a 5th in planning, which will bring us up to 160 places. We have one or two for each area, north, south, east and west Belfast, and that's based on an assessment of need in terms of demography and projections. All our schemes are primarily designed for people with dementia, to provide them with an apartment, 24-hour support.
Okay, thank you. I have Kieran next.
Yeah, thank you very much. Sorry for I missed your presentation, but the question I would like to ask is in relation to the number. Last week the department advised this committee that currently there were 414 supported living facilities for older people across the 5 trusts. However, in your briefing papers you have referred to the trust currently providing between 2 and 5 such facilities. Can each of the trusts clarify the reasons for the discrepancy between the figures provided by the department and the figures you have provided for us?
I think, Chair, that this distinction is between supported housing and sheltered dwellings. Sheltered dwellings are not, we would see them as supported housing. They are simply, they're a housing option for people who choose to go into with low need or no needs. Supported housing is a very targeted...
Well, I hear what you say, but I mean, should that not have been provided clearly on the information that we have? I mean, it clearly says number of supported living facilities for older people. The Belfast Trust, for instance, 137, yet here we have the Belfast Trust who've got 3 and 1 or 4.
Yeah.
It's an awful difference and very certainly misleading.
Well, it's confusing, certainly, and I think it's to do with definitions of supported.
And that applies to all of the trusts. I mean, there's the Southern. The Southern has 44 and 3, 4.
And if you note the Southern submission for this week, we've defined that as 3 supported, as we view full supported, and the other 41 are sheltered. So I would reinforce Marie's interpretation of they probably have referred to both options within the department submission.
I would agree with that as well. I mean, the Northern Trust, we would have 84 sheltered housing schemes.
Yeah, I mean, I think, Chair, it would be better, it would be sensible if we had those figures.
Yeah, I think as well. I mean, it's a fair point. We would hopefully be seeking that evidence back from the department, that clarification back from the department, because it certainly is quite misleading and confusing when we're talking about almost 2 different themes, and those figures don't add up. So, no, I appreciate, Kieran, you raised that.
And the very up-to-date information would be held by the DSD, because that's the department that actually provides that sheltered housing and also supported living from the point of view of the funding for it.
Yeah, okay, thanks, Chair.
Okay, Kieran. Roy, next, sorry.
We've heard that one of the locations where you have there are a small number of vacancies. Are there generally many vacancies or any vacancies in the supported housing schemes that we have?
Well, in the supported housing that we have currently, in terms of the Brook, there are 3 voids at the moment. Those voids tends to be, that's a very big complex up there that has a mixture of like bungalows and other supported living. There's 3 voids in there at the moment. In terms of Barnholt, there are no voids in Barnholt at all, and there are 6 people actually waiting on the list for Barnholt. So that's what we have at the moment.
And the other trusts are...
From a South Eastern Trust perspective, within St Paul's Court, it's fully occupied, and there is a waiting list of 3 for that facility. And in Cedar Court and Downpatrick, which I mentioned is a relatively new scheme, we currently have 8 voids. However, there have been 24 admissions in the unit since it opened, so part of that is in relation to turnover, and there will inevitably, as Marie made mention of, there will be some tenants who come into these facilities who then need to move on to a more dependent model depending on their needs.
And in terms of your projection of future needs, particularly with changes being proposed in terms of such as residential homes, what do you see as being the forthcoming demand to cater that you will have to look after in the next number, say, next 3 years?
I think maybe just if I kind of answer that one. You know, at the moment we have plans. The plans that we've talked to you about the future schemes are up to 15-16. But I think, I understand that there's discussions and negotiations that are taking place between the Department of Health and the Department DSD actually around what funding will be available for future schemes beyond 15-16. I suppose really in terms of the planning for all of that, I think it's important to note, you know, that each trust actually will, you know, outline their own plans whenever that funding is made known to us. Planning also is based on things like needs assessment in an area, capital funding, revenue funding, site availability, identification of a housing association, and then you go into the designing and planning, permission and build. So, as I said, in terms of like future schemes at the moment, until a lot of that is clearer, we just have the schemes up until 15-16.
When you're talking about schemes you're planning for, can you clarify, are all they on the Housing Executive's capital build scheme? Because you can make whatever plans you want, but unless there is capital set aside
Yes.
for them, nothing will result.
I think that's the point.
So are all the schemes that you're talking about in planning on the capital build
Yes.
scheme?
Yes. Yes, the ones up to 15-16 that we've just talked about.
Yeah, and
Yes.
can you clarify, can you maybe come back to us and tell us the numbers of new units, tenancies that will be available when all those plans would be developed? And just a final point then, in terms of supportive living, if elderly or vulnerable population do need this higher level of support, would you agree that there are efficiencies in having them located closer together because you avoid travel time from your carers?
Yes, there are certainly economies of scale in grouping tenancies in one area, you know, so, and particularly for people who have high level of need, who require, overnight calls, several calls, who need constant supervision. There's certainly economies of scale.
Chair, if I could say, particularly the challenge is really in rural areas, and in a big urban area, it's easier to have a larger facility and for people locally to live there. What we find is where we have had voids in some areas, it's because it's not local enough for people. People really want to live as close as possible. Ideally, they want to live in their own homes if they can with support. If they can't, they want to live in their own village or their own town. And our challenge is, when you try to provide that sort of care and support and facilities, it's more expensive because you're talking about much smaller facilities with higher overheads. So it is a real challenge in rural areas to provide that.
Okay, thank you.
Okay, thank you. Mickey Brady next.
Thanks for the presentation. Just a couple of questions. How are people assessed to get a place in a supported living facility?
Well, it's really a combination of, if we start at the point of just a general assessment of people's needs, what we have is generally our integrated teams, mainly social workers, will go out and carry out an assessment, and they'll look at whether a person, what type of care is suitable that would meet the needs of that. And that's a wide range. As Alan said, you know, there's it could be at home, it could be in some other facility. So we start off from that point of view. We try to look. The difficulty with things like supported living is that you're planning way ahead in the future, and people's needs. So you carry out an assessment of need at that particular time, but by the time you go through, all of the bits that we talked about, the capital, all of that, sometime kind of gone past by the time you get your business case and actually, get those in place. So at the end of the day, you have to do an assessment need at that particular time, and that might change as you go through. But again, in terms of then, people who are deemed to be suitable, then there are decisions made. There's usually a panel that has been set up, an admissions panel, that look at the people's requirements and they make decisions. Those panels are made up with health, housing, the housing associations, those kind of things.
Are there any triggers particularly that would point someone towards being assessed for that supported living accommodation?
Well, I think Marie has alluded to the fact, this is the very kind of high end of the market, if you like, in terms of and it's hard to talk about older people as part of the market, but at the end of the day, it's probably people with complex needs. We're talking about small numbers here that are very suitable for that kind of care. Triggers may be things like maybe if they have dementia, that kind of thing, requiring that kind of complex needs.
Are there facilities for self-referral, or does it have to go through, say, a GP and the social work teams? Or?
No, certainly the supported housing schemes are targeted at people who are starting to develop dementia or other frailty, who the family and the individual themselves are forward planning. They anticipate a time when they would require more support and make a positive choice to choose to live in a supported housing option where they can live well with dementia. I mean, it's really the trick in supported housing schemes is identifying people early in their journey, that they have insight into that and their families, and they can choose to live in an apartment or accommodation that uses assistive technology, that has well-trained staff who can provide an enabling model of care that's not institutional in type. People increasingly want to choose that type of model of care rather than the traditional residential or nursing home models.
You've already dealt with it. Just finishing off, obviously there are two departments involved in this, there's Health and DSD. I sit in both committees. And in terms of the provision of the housing, because obviously you provide the infrastructure, but DSD, or the housing associations, have to provide the houses. Already the Minister for DSD has admitted that they failed to reach their targets. So that's going to be an ongoing problem that you're going to have to deal with, because if you don't have the accommodation, you can't provide the infrastructure within that accommodation, and that's an ongoing problem. And obviously that's something you're aware of. And how maybe will you cope, because statistically the elderly population is increasing, but not necessarily more healthily. People are living longer, but with modern medicine that keeps them alive longer, basically. That's going to be an increasing problem unless that issue is dealt with. Because in terms of supported housing, the other thing with DSD was, and it was just maybe you may or may not, I'm sure you are aware of it, the special needs management fees and some, because that's been an issue. We've had, the DSD committees had presentations from RQAA and the housing associations, and they are completely at odds. Stuff that you're getting. And is that something that you have?
The whole SNMA thing is a different issue. I mean, it's an historical funding stream to housing that is provided within housing associations' residential accommodation. It's not open to other residential providers, and it's certainly not a feature of current and modern supported housing schemes.
Moving away from that, yeah, that's really, I suppose, the point, because it seems in terms of transforming your care, that would be part of that ethos, I suppose, to get away from that institutionalised kind of setup. Thanks. Thank you.
I mean, I know, sorry, Madam Chair, I mean, I know that we're not here to talk about that today, but, you know, we keep in mind that these are very complex, you know, people with complex needs, and the vast majority of older people that you're talking about and the demographic changes, they're, you know, the trusts are developing a wide menu of services, a wide range of services to deal with that, including things like assistive living and domiciliary care that you've heard about.
And you see, maybe I just didn't pick that up, but can people self-refer?
Well, I suppose
they can self-refer, but will still go through the same panel process. But they may not have been in direct receipt of health and social care services. They may be coping independently with quite progressed conditions in some instances, like dementia, and they haven't actually got into our loop yet. So certainly some do self-refer, but then they will come into our process where they will get professional assessment and will certainly go through the same panel process.
Okay. And just before I bring Jim on, sorry, just to remember the phones are interfering there with the broadcasting, so just be mindful of how close the phones are to the equipment. So I have Jim next.
Yes. The committee told the department told the committee last week that for 12-13 the trust had spent £3.7 million on providing supported living. Can each trust give a breakdown as to how much they spent?
Yes, well, sorry, go ahead.
Southern Trust spent 200,000.
Advance 200,000.
Well, Belfast spends between 500 million and 650. Each scheme costs around £500,000.
Oh, you said 500 million?
No, sorry, 500,000. Each scheme costs in the region of £500,000 to £600,000, and we have 4.
Oh, it's about 2 million
yeah,
then.
Yeah.
Right.
And if for South Eastern, we have the two schemes currently, accommodation-based schemes, one of which the cost for 13-14 was 272k and the other, the cost was 231k.
I don't have the exact figures in front of me of those schemes, but I have a range that is, I mentioned earlier, we've got a range of other facilities and services that I do have the figures for, but I'm not sure whether that would be any assistance to you.
Process of deduction.
Must be a million.
Yes, if you take, add all four together, then that leaves you with $1 million.
Between the Northern and the... But we can confirm that. We can send that information in and confirm that.
And obviously, under TYC, we would expect that to be increasing. So have you any idea what is in the budget for, say, the next 2 years? Or what you're bidding for maybe is a better question. You know, what's happening? Because clearly the TYC would indicate that this is a growth area, that we need to have better provision for people that prevents them from ending up in more expensive care. So are you planning to expand this? I'm a bit worried that you don't seem to know as yet what you're getting.
Well, that's beyond 15-16. We don't know what we're getting, but in terms of the plans that we have in place for the future schemes, yes, the Trust would have set aside, because the Trust actually funds the personal care element. In terms of the housing itself, that's funded through DSD. So we are aware of what we're spending.
Yeah, but you're not told by DSD what they're spending, what you're then expected to provide the care element of.
But we have forward planned for the projected cost based on all things being equal that for example, in Southern area, that the three schemes will deliver. Now, in the next financial year, there won't be an impact, because even if we're successful with planning permission, or even if Trinity are successful with planning permission, it won't be live in the next financial year. But the year after that, we have approximate cost projected for that.
So how much contact is there between the housing associations, the DSD, and yourselves as to the future? Or do you leave that entirely to them to dictate?
There are processes in place. I mean, at board level, there's a joint commissioning group with representatives from all of the trusts and the housing executive, and that is the forum where assessment of need is discussed and future plans are made. I mean, there has to be a joint assessment of needs in terms of a local area, and trusts then would bring forward business cases around that need.
I'm not detecting much of a dramatic change in gear to provide a lot more of these schemes. I
don't think. I mean, at this point in time, certainly from the Belfast perspective, when we get our fifth scheme in place, we'll have 160 tenancies for this particular group. That's in the context of a whole range of other services that people choose. We believe we're meeting current demand and future demand, at least for the next 2 or 3 years. I think it's also important to point out that we'd want to carry out some evaluation of the totality of the model across the city and probably across Northern Ireland. But this is not a choice for a high percentage of the older population. It's a choice for a very small percentage of the population.
But obviously, as you know, the plans for residential care envisaged, now I don't know what's going to happen now, but did envisage quite a significant drop in that provision, which presumably a lot would have been soaked up by the type of care that you're providing. But you couldn't have done that had it gone ahead, because the sort of numbers we're talking about here would never have met that need.
Sure, I think speaking from our own perspective, we have in the Western Trust 57 facilities covering almost 1,300 individual units. Now, as people have described before, they're from sheltered dwellings right up to the most dependent area, but there are around 300 of those that are jointly commissioned. But we're seeing, and I know we're not here to talk about the other subjects, so please stop me if you want to, but the things like domiciliary care, people are choosing to stay in their own homes, to elect to go into supported housing. First of all, it's a choice. It's a life choice for people, and it's a big decision to give up their own homes. And there's a cost associated with it. Obviously, people are entitled to certain benefits depending on what money that they have themselves. So there's a personal choice, giving up the home, and then there's a cost. So people have to decide on it. But we're experiencing in our residential homes, we have vacancies right across all of them.
And I think it's also important to point out that the plans were in relation to the statute residential. There's a very thriving independent sector residential homes available, and certainly in the Northern Trust we would have a number of vacancies within that sector, certainly that would meet our needs. So whenever you look at, you know, the smaller number of people that would fit supported living, you look at the range of the residential nursing home placements that we have available to us, and you look at all of the other additional things that we're talking about in terms of domiciliary care to meet the needs of older people.
I think it's important not to see statutory residential and home and supported living accommodation or supported accommodation as a like-for-like facility. They're not. We have a lot of people in Southern area within residential care who made a choice to go into residential care because there weren't other options available to them. Some people have been in our statutory residential homes for 18, 20 years, and that is because they did not have options 20 years ago to have, you know, whatever might have better met their needs. And I suppose the current plan, which is the bigger menu-based option, is that whether it's a domiciliary care, a supported home or a supported living or a floating support, there are a range of options that now allow you to make other choices. In our area for the past 6 years, our trends in statutory residentials have been 20 admissions per year. So that's the sort of numbers we've been gauging, and there is capacity within the independent sector market.
I would say that I've been to St Paul's extremely impressed. I would have thought if a lot of elderly people saw and experienced that type of facility, that the demand would rise dramatically. It isn't available in many parts of the country, but when people understand what it involves, I'd sign myself in. I was a few years older, you know, it's that good. So that's what I promised, by the way. You know, to a lot of people, this is a totally foreign concept because there's nowhere in their area that provides it. Thank you.
Okay, thank you. Gordon?
Thanks, Chair, and apologies for being late there. In relation to publicising supported living as an option for older people, how are the trusts going about doing that? Making people aware of what facilities are available?
Certainly within the trusts, what would normally happen is people would have their needs assessed in the first instance by their social worker or care manager, and that supported living would be one, and supported housing would be one of the things that would be available, and people would be informed about what's available within their locality. And as I mentioned earlier, people really want to live locally. They don't want to move 10 miles down the road, 20 miles down the road. They want to stay in.
Much aware of that as local representatives, yeah, indeed. That is a big factor.
Maybe I could say in relation to Cedar Court, our new facility in Downpatrick, we've done a lot of publicising of that, including we've developed a DVD which is being used widely in publicising the facility and what it can offer. And we have that on our trust website. So as well as it being a one-to-one engagement when needs assessment has been undertaken by the professional with an individual, we're also doing everything that we can to ensure that the wider public have an understanding of that as an option.
I mean, from Belfast, we've just opened a new one on the Shankill Road, Hemsworth Court, and it's in the process of becoming occupied. And there's been a significant amount of work with our partner. What do you call it? No, it's the Housing Association. Just get. No, Helm Housing and the Belfast Trust. They have driven that, and we've produced a DVD. A lot of work with local community groups, local GPs, local older people's groups, you know, local newspapers to try and have that word of mouth, because that is the most effective.
But Helen, they're providing the buildings,
yeah,
the infrastructure, and user.
We provide the care and support.
The support within it. Yeah, yeah. What about the trusts? Have they been asked by the department or the boards to actively promote supported living? Is that a fair statement?
It's part of what. It's basically part of what we would normally do. And just to add, I meant to say earlier that beyond the one-to-one, as Nicky has said, we've had in some of our areas where perhaps the uptake hasn't been as good as we anticipated. We've had open days, we've had adverts in the press, we've worked with the Housing Association to try and promote the usage of that, and we've had to think about other programmes of care. Ours, or the one that I'm thinking of, is aimed towards people who tend to have the early stages of dementia, but we may then open that up to other frail elderly people.
Is dementia, is that not being covered more by the private sector?
Well, I think it's back to the menu of options that we've mentioned. So this model is one of a menu of options, and that applies be it for dementia or be it for frail elderly.
I mean, both of the supported living accommodation that we have currently within the trust is directed towards people with dementia and older people as well, so it is a mixture. specifically.
Yeah.
Yes.
I mean, it's important to highlight that the vast majority of people diagnosed with dementia, and Northern Ireland has the highest rates of diagnosis of dementia, live well with their dementia in their local communities with their families. Supported housing is an option for some people who can anticipate the future and make a positive choice. So most people are not in the private sector with dementia.
It's really at the nursing care stage where the independent sector will kick in for dementia support.
Some new homes opening for the nursing side. Okay, thanks, Chair. Thanks very much, folks.
Yes, I just wanted to come in on a small point at the back of Gordon's, which is, what's best practice in this regard? Because clearly you're employing different techniques, some similar, but what's best practice? And how can you identify, if you like, the population before they reach crisis point? Very often they interact with you at a crisis point of some sort of nature. And is there information and potentially budget set aside for preparing information to allow people to know what's coming forward, given that everything here is stating that we're having an elderly population living longer?
There is information that we do have within the Trust around the range of older people's services that we provide. We have that on our website. We have a plan for older people's services, and that again is up on our website. We've also been round I personally have been round a lot of the council areas within the Northern Trust, and as you know, we have 10 councils in there, so we've been round there talking about our plans for older people's services. We do have publication around, say, Barn Halt. We have leaflets, we do the DVD, and I think Nicky spoke about DVDs, we do have those things. So, where we get opportunities, we have older people's panel, we talk about our services for older people, and I think it's important to actually see that we talk about the totality of the services for older people, so that, because it's never like one size fits all, it's a range of things that we provide.
Could I just add to that, just to back it up? I think it's even more upstream than that in terms of partnership working. We have a lot of partners that we actively work with in community development approaches and working with communities in terms of AGNI, Pensioners Parliament. We also have age-friendly initiatives happening with our council colleagues to try and get that bigger approach within society to how are we going to support our older people and their increasing needs. We have a host of community conversations happening now across Southern area to try and listen to what older people are telling us, being informed by them as we move forward and shape our plans. And we obviously have an active legislative backdrop in terms of active involvement with our communities. So I think there's a big piece of work that is upstream there, and then the promotional stage. And is there a defined budget? Technically, yes. We have a lot of support from our communications department, and where there's a need to develop resources or whatever. It's not a defined budget as such, but there is a communications budget there that we could draw from.
And just go back to your point on best practice, Fergal, I think our experience in Belfast has been that whoever runs the service, particularly on the care and support side, needs to have quite an amount of experience in dementia. The activities for older people have to be meaningful. With strong partnership and joint working with our housing partners, well-trained, supported and empowered staff, good policies and procedures, strong management locally, strong community links, particularly links with the PSNI, local shops, community groups, use of simple, effective technology to reduce risks for people with dementia. So those are the key components that we would say, because this is not an easy model to deliver, and it requires a very strong team.
I think the challenge is to have the conversation as early as possible, as people have said. I've attended some of the pensioners' parliaments, and I think working in health and social care, you perhaps get a distorted image of what older people are about, because you tend to integrate, you're engaged with people who are in difficulty or are challenged with their health. But when you meet older people who are well, their concerns are around things like safety, policing, pensions, transport, and maybe housing, but they're not thinking ahead of their care. Now, I'm sure if ask any of us, would all have an idea about what we'd like in the future, but very few of us actually go to make a plan about it, and it is. I think we need to have those big conversations with people earlier.
Okay, is it on this?
Yeah, just on the conversations, and you mentioned conversations in the Pensioners Parliament. No, it's on your end Friday, so and it's a very important vehicle for people. But we have an older persons commissioner, and really whole ethos of that is to put older people at the heart of any issues which affect them. I'm just wondering, have you had much contact with the Older Persons Commission in relation to all of this?
Yes, we have had a number of meetings. Individually with trusts, but also we've had collectively. All the trusts have met with the Older People's Commissioner. I think also too there's in the future, which will be very, very important, with the councils being given the lead for community development next year. I think it's also important we're starting to set up a lot of networks, and having those conversations and partnerships.
Okay.
Thank you, Chair. The QIC implementation plan states that the improved availability of supported living places will mean that the demand for places in residential homes will decrease. Can each of you quantify how many people over the next 3 years you expect placed in supported living who previously would have been placed in residential?
Well, what we do have is we've given you the plans for the places that we have developed or in development for 15-16, and I think each of the trusts have given you those numbers. It's very hard we can generally plan on demographics, on local areas. We take into consideration all of that, and we try to plan in terms of the percentage of older people that will require whatever type of living accommodation. But whenever it comes to the time, it is based on the individual assessment. So whilst the trusts look ahead and try to think about the number of placements that we need for whatever it is, we also think about the type and level of, say, domiciliary care that we require. We look ahead for the floating supports. I think then there is an issue around, whenever you come to the reality of the situation and what we're doing. But I also think it's also important, I know in the Northern Trust, we have had an older people's strategy that we developed in 2006. And it was there for 5 years, then was superseded by TYC. But we have been on the journey around, because at that stage, whenever we met with older people and we had focus groups, met with them, and they said they wanted to live in their own homes for as long as possible and as close to home as they can. So our plans have been based, and everything we've done since then has been based on that. So what we've done is we've increased our domiciliary care right across. In the last few years, we've spent an additional 6.5 million with domiciliary care. Our placements, in terms of permanent placements, we have seen that been reduced over the years, because we are actively trying to promote the services which are going to help people to stay in their own homes.
You can't actually quantify.
Well, I think it would be hard for me to say just here and now. In 3 years' time, we anticipate that it's 20, 40, whatever. We do have general plans for what we see as year on year, based on demand.
From the Western Trust, I can't give you an exact number either. What I can say is we have sufficient across the Trust geography at the moment, the exception, as I mentioned earlier, of Strabane, which is, there's a gap there in terms of supported housing and other types of housing for older people who are in need, and we're working to try and promote that. But I think, as Una has said, there's a way, a broad recipe of things that people may need or choose, from the most basic but critical personal alarm that somebody might wear around their neck when they're living alone and they're feeling vulnerable if they happen to have a fall, right up to supported living and everything in between.
And similarly, from South Eastern, a specific figure, we wouldn't be in a position to. I think it's maybe important to note that when we're looking at supported living for older people, it's on a population-based needs assessment as opposed to individual, which would be the case, for example, in resettlement of our learning disability population, where it is specific looking from one individual to where they may go in the future. We're looking at the service needs for a population and a menu of options for that population. What I would provide the reassurance in relation to specific numbers, were it to be the case that every single client within a residential home, and this is not a scenario that any of us would anticipate, but were it to be that every single one of those clients were to require to move to a supported living environment, there would be capacity within our plans up to 15-16 to enable that to happen. But that's not something that we would anticipate, because it's only part of a menu of options.
From Belfast's perspective, I mean, we've seen a very steady and clear decline in residential care across all the providers. So again, it's difficult to predict actual numbers because it depends on turnover and current schemes and new schemes. But certainly, people are choosing less to go into residential care. That is very obvious.
And from Southern's perspective, I've already said to you that on average we have 21 admissions. If we look back across the past 6 years across our 5 statutory residential homes, 21 is the total across those 5. We've also seen up to 13% decline in demand for our statutory residential homes. So with putting that against the demographic trends, it's likely that we will have 23 to 25 who potentially over the next 3 years may have come in each year to our statutory residential homes. If we have some of those, and we don't know that because we're obviously just closed the stage 1 consultation, if we have some of those or all of those or none of those, that remains to be seen. But we would potentially will be able to divert those who do not wish to remain with a community package at home towards independent sector residential homes, and then we will have hopefully all things being equal 48 new places coming on board which will help us absorb that across Southern area.
I suppose just by way of bringing this to some sort of conclusion at this point, initially my first question I'd asked about the Trust's understanding of the departmental policy in relation to supported living, and I heard specifically Marie and maybe some others indicated that supported living is for a very small part of the population. Is that a vision that has been interpreted or passed on from the department?
No, I don't think. I think it's just this is a model of care which is very specialised. It is very expensive, both capital and revenue, and needs to be targeted at people who most need and who could most benefit from the model. It's not something that would be open to every older person who wanted to live in a supported in a community type environment. So from the point of view of the department and trusts, it is very targeted at those who would most benefit from it, because it's expensive both for the state and for the.
In your views, is there enough forecasted planning or targeting of where, given that what we have, and I'm accepting what you're saying in relation to trust and the complex issue and indeed choice rather, but we know the population forecast. So is there enough of a strategic approach in terms of that forecast and targeting that is required?
I think it's very challenging because there's a lot of different initiatives that are all contributing towards meeting people's needs. So we all know about the increase in the over 65 population, and indeed the over 85s, because if you go into any of our hospitals these days, it's not people over 65, it's the 80-year-olds and the 90-year-olds, and often people with comorbidities, people with dementia, people who need a lot of complex care. Alongside that, we have things like long-term conditions management, where we're trying to help people manage their own illnesses at an earlier stage to help prevent hospital admission, because nobody wants to go into hospital unless they desperately have to. And we have seen some success in that. Then we've got domiciliary care. So we have lots of different initiatives.
Is there enough?
Well, my understanding at the moment is that there's very high-level negotiations going on at the moment between the department and the DSD around, supported living and what the requirements are, what the targets should be, what the funding should be.
Well, it certainly wasn't the interpretation that we got from the department and their evidence that there was any kind of strategic approach to this, given the fact that we know, you're quite right, Alan, the over 85s by 2020 and the increase in 40%. But somehow there was a ratio applied because there was the 414 facilities and the 5 proposals. So somebody somewhere is applying a ratio. But my point is, again, is there enough of a strategic approach to planning?
I certainly think the provision of supported housing is a relatively new phenomenon in the system, and I think it would benefit from formal evaluation and some strategic thinking about what is needed in the future and how much it would replace high-end accommodation and care, i.e. nursing and residential. But that is an unknown, I think, to most of us at the moment.
I think, Chair, sorry, transforming your care points the way. But my understanding is there isn't a huge amount of new money coming along. It's the money we have, spending it differently. And the whole emphasis is meant to be on the reduction of expenditure in acute services and work more spent in the community, and we need to see that coming into reality.
Whereas you need planning to do that and have an outcome framework attached to it. Roy, on this issue.
There's a comment there that this is an expensive option. I haven't got it in front of me, but I remember seeing something. It costs the Health about £175 a week, if I'm right. Sorry, what is the cost?
Each scheme is priced differently depending on the level of support that goes in. But schemes in our area would be for the older person who pays in and around £300 a week, £250, £300 a week. Now that is quite an expensive option before people buy food or because a lot of the facilities do not do meals or.
But is it not considerably less than the cost of residential care if you have to place someone into residential care?
Residential regional tariff is about £460 per week, so it is significantly less. But in residential, you'll get all your laundry, you'll get your meals, you'll get full 24/7 care, whereas people in supported living may have other costs to attribute. Now, they obviously have different streams that they can pull from in terms of potentially housing benefit or supporting people allowance or pension credits, attendance allowance that they can use for that. But for those who have the ability to pay, it is quite an expensive option.
I have another question. You want me to come later? Or?
No, go ahead.
Okay. So specifically for the Northern Trust, and it may relate to others as well. You've indicated two supported living accommodations, the Brook and Barnholt. I'm curious why the supported living at the Scarl residential home is not mentioned. I understand there's 10 places there, and the proposal to close it will give you negative 10 places. So my question is, do some of the other residential homes also provide support to separate living units attached to the other residential accommodation? And why are the supported living places at the Scarl not listed?
Supported living places in the Scarl. I suppose really in that Larne area that we're talking about, I mean, there's a wide range of services that are provided there, including Liscarl that you talked about. There's also Inver Hospital for intermediate care. There's also a number of sheltered.
10 supported living places.
Yes. I'm sorry, your question?
The question is, why are they not listed?
Well, I was thinking in the context of the supported living, specifically supported living. Liscarl, as you know, is a residential home with some units that are supported living as well. So in terms of the model, I understood we were talking about like Barnholt, but you're quite right. There's 10 supported living places there as part of the residential home that is there at the moment.
So are there any other trusts area in this model? So just to highlight, there's negative 10 places, proposal to close those 10 places with the proposal to close the residential home.
But again, too, I think in any kind of future planning for that area, you know, we do need to look at the range of services that are provided within that area, including, you know, the sheltered accommodation and all of that, the totality of it.
But the Trust proposed to close it without doing that?
Well, as you know, the proposal, as you know, the residential homes is there's the regional consultation that's just ended there on the 7th of March. What we will get an outcome of that, and then we will apply that across the trust area and put forward our plans.
Okay, thank you. Yeah, quickly, yeah.
Do you all of you share Mr Corey Finn's point that not enough money has been shifted quickly enough from savings into the community side?
Well, I think
if I've interpreted you right, yeah.
I think it is.
Your words, not mine.
Yeah. Well, I think that's a challenge for everybody, because I think that you know, the services are required out in the community, but as we know, to free up funding from secondary care into community, you know, you have to get a cohort of perhaps beds and all the infrastructure to close to be able to shift that out, and that doesn't happen immediately. So you know, there is a need to have that kind of bridging that takes place between shifting those services out, and then the money presumably will follow behind.
I think the thing is that in days have gone by when we would have changed from one model to another, we would have had money to do the change, so to sort of double run. Clearly, the health service and the country is challenged financially, so we don't have that luxury of having the money to run double.
Mm-hmm. But is that not at the heart of a lot of the stress that's in this system? that if you were to work it from the other side, in terms of providing there, that would take the stress off here. And you're suggesting that in another environment that would be possible.
Well, as I say, in years gone by, we would have had those monies to address. It was called change monies, and that we are challenged. We just don't have sufficient money in the health service nor the country to do that.
And I mean, there is pressures there in the system. I think you're quite right. I mean, in terms of like shortening lengths of stay within hospital, which means that those people come out, into the community at an earlier stage, and so there is a shift that is taking place there as we speak, even.
And can I ask just one other point? That's very illuminating, by the way. I find that very instructional. But can I ask another question just about the all of the graphs that we see point to the ageing population growing and growing? Is anybody doing any interrogation within those figures of where people are likely to end up, or are they going to be less healthy? Are they going to be flatlining, or is it going to be, maintaining an elderly more healthy? Is there an interrogation being done? And I know you can't read the future, but is there an interrogation being done of the likelihood of where these people will end up within the health spectrum?
Well, we do try to predict as much as possible. There's a lot of analysis that goes on within trusts, and I'm sure the department and the board as well, in terms of trying to analysing where spend should go. I mean, for example, we've heard about reablement, and reablement, all of the trusts have implemented that in some shape or form. But where it has been evaluated, it has indicated that it tends to keep people at a certain level where it works really, really well. It keeps people at a certain level for maybe 18 months to 2 years. But then it kind of just delays sometimes the deterioration and what is required at a later stage. So, I mean, I think it's a very quickly changing environment that we're working in. I mean, certainly for us who have worked, in the NHS, we've seen quite a lot of changes, even 5 to 10 years, around what's happening. But it is a challenge.
And I think the lived experiences, obviously the financial position across the trust is well known. There is demand out there when you're assessing need on an individual basis, on a daily basis. It's very hard not to respond to that need because the pressure is there. I think we have to get smarter with the collective resource, and I'm talking across our community, our voluntary sector, and how we work with families in a partnership model of care that more looks at, if this is the need of the older person, how can we meet it together, because we can't meet it through health and social care on our own.
And in answer to your question around the analysis, the risk stratification that's currently taking place through the integrated care partnerships will help us as a system to have a better understanding of what the future might look like.
Okay. Thank you all. Can I maybe just ask, by way of conclusion, that the questions that was asked around the kind of clear figures on projected demand, with the caveat that it is difficult because there is a choice element, but projected demand and projected costs from each trust, that you could maybe furnish the committee with those figures. Okay. So I thank you for your time today. That's been informative and appreciate
Madam Chair, for
the
the
detail.
record, could I just say that my name's Una Cunning rather than Canning?
Apologise for
Just
that.
That's
Okay.
all right, that's
Thank
fine. It's
you.
just for the record.
Thank you for that. Okay, members, moving to item 6, which is the proposed statutory rule, the recovery of health services charges. Amounts Amendment Regulations 2014. Refer members to page 66. We had considered this SL1 at the last meeting and agreed to write to the Department for further information. Referring members to the response from the Department, which is at page 48 of your tabled papers. The Department has advised that the Compensation Recovery Unit can recover health service charges from both individuals and insurance companies. However, to date, reclaims have only been made from insurance companies. So are members content for the Department to proceed with the statutory rule?
I think the question was it insurance companies that it would be recovered from? Because that's the issue. Because it was a situation previously, and I had raised it, that people who were entitled to compensation lost all the benefits that they got because it was taken directly. And that was amended that the insurance companies should pay for, but that seems to be the case now.
So that's clarified.
But there is a proviso there that they can take from individuals. That doesn't seem to have happened.
Okay, okay. So you're content enough to proceed, members are content. Okay, item 7, members, is the learning disabilities and health inequalities. The Minister's response to the report on the committee's review is at page 77. There's also a briefing paper from the clerk at page 50 of the tabled items. I'm going to ask the clerk to brief members.
Okay, Chair, the committee's report made 8 recommendations, and I've just summarised basically the department's response on each recommendation. It's under some of the recommendations the department has made a commitment to do what has been asked. However, on a number of them, they haven't. For example, recommendation 3, the department has not agreed to ask health facilitators to make contact with the voluntary sector providers in their area. And recommendation 8, the department has not agreed to do any preliminary research into potential systems for creating a central register of people with a learning disability. On Friday past, myself and Leslie Ann Black from our research team attended the Learning Disability Conference, and just one thing that came out of that was there's a presentation by the RQIA, and they have done a review against looking at the Trust's performance against the what's known as the GAIN guidelines for caring for people with a learning disability in general hospital settings, and that is to be published shortly, and it might be an idea for the committee to take evidence from the RQIA on that review when it's published. I know the committee has previously taken evidence on other RQIA reviews, and also I suppose with these recommendations it would probably be sensible to give the department some time to make progress. So a suggestion would be that maybe in 3 months' time the committee would seek a further update from the department.
Sure. I mean, on the recommendation number 8, I'm surprised, amazed that they're not. In fact, I was amazed that they didn't have a central register for people with a learning disability in the first place. And I think they should have. I think that's. And for to say that they're not going to do it, I think that we should speak very strongly that they ought to do it and have that at their fingertips.
I think it was one of the issues that how do you assess the need, or how do you target the support that's required if you don't even have the actual statistics. So absolutely, I mean I think we should go back to the department on that one and express our concern that there needs to be some sort of central register
it just
for people with learning
appears to me that by not going down that road, they are perfectly happy to allow certain people to go through the net that they don't want to know about, and shouldn't be allowed.
Okay. So if we go back to the department and seek that view specifically on that, and then depending on what response we get back, we'll agree as a committee what the next steps would be. Yep. Are members comfortable enough with that? Okay. Item 8 is the forward work programme. I'm asking members just to note that, which is on page 127. Item 9 is matters arising. Asking members to note items 9.1 on page 130.
Before we go on to the forward work programme, we are of course updating it with our visit the Royal being removed, because it will appear on our website, etc. As we're going there, and we are not going there next Wednesday.
Item 9.2 on page 132 is a response from the board regarding outpatient intravenous antibiotic treatments. I'm suggesting, members, that the committee forwards a response to the Belfast Trust consultant who had originally raised the issue with the committee during an informal meeting.
Great.
Items 9.3 and 9.4 on pages 54 and 55 of the tabled papers deal with ovarian cancer. Item 9.3 is a response from the Minister in relation to the committee's request for a specific public awareness campaign on ovarian cancer. The Minister has stated that there will be a general public awareness campaign on cancer with tumour-specific messages, including ovarian cancer. Do members have any comments?
I don't think, Chair, that it's good enough. We have supported, and I'm thinking particularly in Una Cruden, who has been a a major influence on what we're trying to do and has put her head above the parapet, and she wants to see, and I think we have supported her endeavours to have a separate ovarian cancer awareness campaign, and this is not going down that road, and I think we should be speaking strongly to get that individual ovarian cancer awareness campaign.
Okay, thank you, Pam.
Thank you, Chair. I would agree with Kieran. Very disappointed actually with the response, and I think under the circumstances it's only but right that we do strive to get this solo campaign. And I think worst case scenario, I would want to see amongst this bigger campaign, very big emphasis on ovarian cancer and maybe any other cancers there of similar nature that heavily rely on this awareness. Because at the end of the day, we have the department here and they're able to tell us they've written to GPs, but without actually empowering the women in the first place with the knowledge that they need, they will not present to the GPs. So I think it is of vital importance that we do seriously raise awareness on this issue.
I would be in contact with Una, I suppose, practically every day in life, and she's very persistent and quite rightly so. I met the Minister yesterday and made it very clear that I was very disappointed and the committee were disappointed with the lack of movement from the PHA on this. And I understand that the transcript of the hearing has been read by the PHA, and I think that they're catching the drift. The committee is unanimously against it. And I'm hoping that the Minister will indeed have another look at this, because Una would be quite content for me to say this. Una, it's remarkable that she's made it this far, and she wants as her legacy for this to happen. Also, of course, she was, I don't know, did we note she was voted Belfast Telegraph Woman of the Year? Yeah. And I don't know, I had to leave early. It might be incumbent upon you, Madam Chair, to write to her, to congratulate her on the achievement, if that's acceptable to members, and to keep pushing this issue, that this is an extremely valid campaign. And we don't fall out with the Minister too often, but I think in this one, we need to keep pushing.
Okay, no, absolutely. Farewell, yes.
Just without doing it wouldn't be the focus. And therefore, I think that underscores the increased need for a campaign, and particularly that early diagnosis makes a difference, and point to the amount of deaths that happen annually as a result of ovarian cancer.
Okay, so Michael, yeah.
No, it's just, if it goes into a kind of a group thing, it'll be subsumed into a general awareness of different forms of cancer. I spoke to a constituent last week, actually, who had abdominal pains and went to the doctor. Now, they were aware of Venus' campaign and were able to ask for the blood test. It seems a very simple way of diagnosing something that can kill you if it isn't diagnosed quickly enough. And I think it's a big issue, and I think it needs a standalone awareness campaign.
Okay, and Pam, you had, I think, some comment.
I'm just going to add that, I think it wouldn't be unreasonable, given the instances of ovarian cancer, and I know the department concentrated on over 50s, but there's women, my age, dying with it, and I'm 42, and women that are younger, and obviously that's what inspired them in the first place, because of the age of another friend who died at the same age as her daughter. I think she was about 36, and I think we can't forget that. And I think it would be worth suggesting to the department that they could consider offering the blood test as part of the screening process, even connected to cervical smears. Because, at the end of the day, I'm sitting here as a 42-year-old woman. I didn't know anything about ovarian cancer or the symptoms until last March when it was debated. Mm-hmm. Without that debate and without that knowledge that came to us through Una Crudden, I still wouldn't know. And another point as well, which Una made to me, was what about the women who do have IBS? How are they to be protected or looked out for in relation to ovarian cancer? If it's simply written off, as the symptoms can be mistaken for IBS, how are they to be protected? There needs to be some form of screening.
Okay, members, I'm taking from this that we go back to the Minister on this. It remains our view that there needs to be a standalone awareness campaign in relation to this issue. The statistics speak for itself. The 3% of women who feel actually confident to identify the signs needs to be challenged and targeted. So, members comfortable? We'll go back to the Minister and express our concern, and it remains our view. Okay, members. Item 10 is correspondence. I'm asking members to note items 10.1 and 10.7 on pages 136 to 182. Items 10.8 and 10.9 on pages 183 and 184 are in relation to the endometriosis services. As members will know, the committee brought a motion to the Assembly on this subject in June 2013 and suggesting that we write to the Department for an update on the proposals to improve services for women in 2014-15 and beyond. Thank you. I'm asking members to note then item 10.10 on page 185.
Great.
Item 10.11 on page 188 is a letter from the Patient and Client Council asking to present their recent report on chronic pain at a committee meeting. The report was launched a few weeks ago, and I would imagine that some of the members here were at the launch or have looked at the report on the website. I myself met with the PCC earlier this year, and when they briefed me on the proposals for the piece of work. So I'm suggesting it would be more useful in terms of the committee's scrutiny role to write back and ask them to provide a written brief, first of all, on how they intend to engage with the HSC organisations to ensure that the recommendations in their report are actually progressed. Are members comfortable with that approach at this point?
Great.
Thank you. I'm asking members to note item 10.12 on page 189. Item 10.13 on 191 is an invitation from the Joseph Rowntree Foundation inviting the committee to visit one of its facilities in the north east of England as part of the review of supported living. Item 10.20 on page 57 of the table papers is an invitation from David Law to visit the Pavilions model for supported living, which is a private enterprise. The clerk will draw up a suggested programme of visits and further evidence sessions to be considered at our next meeting, so we can discuss that further then if members are in agreement. Okay.
It won't be now until that fortnight, of course.
Yeah.
Does that
and
impact?
again, if members do have any views on taking up these offers, we can come back to them and discuss them in more detail. Asking members to note item 10.14 on page 193. And item 10.15 on page 195 is correspondence from Mr William Houghton in response to the committee's letter referring him to constituency representatives for support. Are members content to write again to explain that it cannot become involved in cases concerning individual facilities and their relationships with the HSC Trust, and again advising that he contacts local representatives for further support?
Great.
Asking members to note items 10.16 to 10.18 on pages 196 to 134 there, but I'm thinking that's...
Sorry, must be a typo.
It must be 204, yeah. Item 10.19 on page 218 is correspondence regarding a personal case. Are members again content to refer the correspondence to constituency representatives for support? Okay, any other business? Do members have any other business?
Chair, I have two. One is, would it be possible to write to the Minister of the Department for an update on the complementary alternative medicines to be incorporated into the National Health Service? Apparently there was a research done in Michael McGimpsey's time, and it was presented to the Minister at that time, and there was no action taken. This would, I am led to believe, help the older population to overcome problems. I'm just saying, could we ask for a letter to go to see if there's any consideration or any plans to introduce that
The
to the
clerk's
NHS?
informing me that we had as a committee last year, to our understanding, written
Chair.
off.
Yes, it was following the visit to the, I can't recall the name, the centre in West Belfast, Conway Mill, with the previous chair, Sue Ramsey. And on the back of that visit, the committee did write to the Minister to seek an update on complementary therapies So it might be helpful if I will dig out that response.
Yeah. And we can circulate that if that would be useful. Okay.
The other thing was, it has come to my attention that there is extreme pressure under the ambulance service personnel. In fact, they're almost getting to the stage where they're unable to cope in terms of the workload, and I suspect this is coming from the closure of the A&Es. They're having to travel to different places, and I wonder, could we write to the chief executive of the ambulance service, pointing out these difficulties that's now being experienced by members of his staff?
Would it not be better to maybe seek a view from the Chief Executive Office to, what the issues might be, rather than us pointing out to them?
I'm just bringing it to the committee's attention before there is another crisis in the health service. Staff are not turning up, they're unwell, and it's putting the extra burden on other staff. They're having to work through tea breaks, they're just not getting, and they're almost at burnout.
The point taken. Okay, I think maybe what I'm going to suggest is that myself and the clerk think about the best approach to this, and maybe come back to yourself if you're agreeable to that. But I mean, the point's well made. It's just about probably getting the right information back that we need.
Thank you.
Roy had indicated.
Sorry, to come back to the correspondence we received from Hugh McCloy. One of the issues that is included in that is again the issue of misreporting. He's indicating that a patient was indicated to have been admitted from A&E to the ward at 4:07 a.m, whilst in reality the patient was still in A&E at 10 a.m. How does that work? I mean, I think we need to delve further into that. Either they are in the ward or they're in A&E. Was nobody looking after her whilst the patient was in A&E and admitted to the ward? What's going on here? Is this further misreporting?
Is this something that I'm just responding to the member, but the minister's due to make a statement, or at least a statement this week, said that he was coming back with update on proposals around emergency care. Is this something that we should ultimately get that response from the minister and the department, and look to see where misreporting or reporting generally sits within that? Are you happy to do it? Because he has indicated this week that that's forthcoming and fairly soon.
This is very, obviously very factual information, and as long as we continue to progress it, if necessary.
Okay, thank you. Nicky?
No, it's just a huge point about the chief executive of the ambulance service. He's doing his job. I don't mean to be facetious. If he's doing his job, he should know the pressures his staff are under. I mean, I'm sure. That's the point. Not so much that I know.
I think that's why we want to reflect on this. Extracting the information. Gordon.
Thanks, Chair. Just a number of us attended a conference last week. One of the issues that came up was about connected health, about innovation, research and development, funding that's available. There's a considerable amount of people within the department now working on this initiative, and obviously committing quite a lot of resources to it. I think it'd be good if we got a briefing on connected health, how it's obviously been integrated with transforming your care. So I think that'll be useful. We could programme that in sometime.
Can we write to the department on that? Are you
Yeah.
happy enough to write to the department? And because there has been progress between the Department of Health and Derry, specifically around
As
Belfast.
you know, as a former member of Derry,
yes,
you're very much aware of it.
and there's some work that's ongoing in the northwest as well around it. So happy to
We get a ring up there.
happy to do that.
Definitely.
Anything else? Okay. Remind members that the next meeting is now next week, which is what date? 26th. It's the 26th of March, sorry, starting at 2 o'clock in the Senate chamber. Thank you.
Thanks, Megan.